Welcome back. Day 2, Eyes on 2022. I'm Dr. Damon Dierker. I'm your co-host in the exhibit hall and program chair. And I'm honored to bring a true friend and mentor on for our next interview, Dr. Laura Periman. Our session is entitled Deep Dive on OptiLight by Lumenis. Laura, it is great to see you.
Hi.
It's been a while. We saw you. We saw each other briefly in Boston a few weeks ago, but how have you been?
Really good. It was awesome to see people in person, and that was a great meeting. You know what my favorite part about that meeting is how we started our presbyopia session at 8 a.m. Wednesday morning, and there was nothing on the carpet. And by the time we came out, all these names of all these people who had achieved their FAAO, I was just like, I just love how that's celebrated. I think it's such a great accomplishment, and I love how that's celebrated.
And for many of those, it was a delay. I had a colleague at my practice, Nathan Morrow, who had to celebrate a year later because of the pandemic. So it was actually 2 years of fellows.
Wow.
Yeah. So let's get right into our session here, because I know you've been dubbed the dry eye master by everybody in eye care, and rightly so. You have certainly been a leader in this space and a mentor to me personally. You write extensively on ocular surface disease. You're leading the way in education, former dry eye boot camp faculty, Eyes on Dry Eye, Eyes on 2022, in addition to all the other things that you're doing in optometry and ophthalmology. So tell me a little bit about your passion for dry eye and where that started and why you focus so much of your career on ocular surface disease.
Oh, wow. Well, thanks for that question. I've always loved eyeballs. I remember being a kid growing up in the wilds of Montana, being fascinated with the eyeballs of frogs and fish and different animals I'd find out in the wild there. But I knew I always wanted to be a doctor since the age of 12. And was lucky enough to apply for and receive a scholarship as an undergrad to study at the Oregon Regional Primate Research Center, where I did molecular biology on pro-opio melanocortin gene expression in the primate under hormonal conditions. Sounds crazy, but it was actually the seed for the rest of my career, because with that molecular biology experience and knowledge, I was able to apply for a role at Immunex, where I worked on Enbrel. And that's where the passion for inflammation and immunopathophysiology came about, was there. Put my husband through law school. I went on to med school. I got the better end of the deal. It definitely was more expensive, more blood, sweat, and tears. Thank you, honey. But anyway, so yeah, I have come at it from this deep science perspective, this molecular perspective. I love understanding how things work. It drives me nuts until I understand the mechanics of something. I have a very mechanical brain as well. So yeah, I'm a forever student. I've been studying my entire career, and ocular surface disease is where the rubber meets the road. I'm able to apply all my interests and all my passions in one disease state, where I can make a tremendous impact for these incredible patients. So that's the short answer.
And being able to take all of that incredible in-depth knowledge and then bring it to the masses in the form of a Dr. Seuss themed explanation of pathophysiology of dry eye. So I think it's just incredible what you're able to do, and just the amount of knowledge and the dedication really to the profession. Is you've done so much, but there's so much more out there. And we see that this whole space in ocular surface disease is just exploding. And my take on this is, if you're not doing this now, if you're not embracing this as an optometrist or ophthalmologist wherever you practice, where are you going to be in 3 or 5 years when there's so much more out there? So understand the tools that we have now. I'm looking forward to the tools that are in development, but there's so much more now that we have compared to just 5 or 10 years ago. So thank you so much, Laura, for helping us understand how to use these new tools like OptiLight to help our patients have better outcomes.
Thank you for the opportunities over time to share and teach and explore and elevate all of us, really. And at the end of the day, the more we work together, the more we approach this as a big tent, as an entire eye care community, the more our patients will benefit, because there's a lot of people struggling with dry eye. It's all hands on deck, in my opinion.
I agree. And to that point is, why are they struggling? What is it that we aren't getting right as eye care professionals in terms of how we understand both the diagnostic tools to have for dry eye disease and what we do to help these patients therapeutically. Where's the knowledge gaps?
Well, I think it comes from many things. At least in the course of my career, when I first started treating dry eye, I didn't even have a prescription medication other than steroids. So I've seen this evolution of the therapeutic options come about, and drops are important. They have a role. That constant immunoregulation of the pathophysiology, very important. Using steroids to treat flare-ups, absolutely important. But then there's this other aspect of ocular surface disease, and I call it the BSTO, RAR. And a lot of people have heard me explain this before, but it's essentially the interrelation, 6 interrelated mechanisms of meibomian gland dysfunction. It's not just altered melting temperature, it's the BSTO. B is bacteria and Demodex. E is enzymatic compromise. The biochemistry is off inside the gland. I is inflammation. Inflammatory cells are surrounding those meibomian glands and smoking and drinking with their inflammatory cytokines, making the stem cells sick, compromising their function and ability to produce a healthy meibum. S is stasis or constipation. That's how I express it to the patient. Constipated oil glands. T is altered melting temperature. And finally, O is obstruction. And so when you look at the peer-reviewed literature and really study the mechanisms of where these different modalities can be applied in the BSTO construct, 5 out of the 6 heads of the BSTO with OptiLight. And that's why I can achieve, with that technology, I'm able to really give that patient big forward momentum push towards improving their ocular surface with the OptiLight treatment, because I'm getting 5 out of the 6 heads. Nothing we have gets all 6. This is why we layer therapies together. But OptiLight is my go-to, honestly, for getting that meibomian gland dysfunction, inflammation load, all of that stuff under control. And then all my other things work better.
No, I agree. And I find myself, with a couple years of IPL experience under my belt, it's almost hard for me to justify not recommending that for the vast majority of my patients. I almost feel like that's where we have to start and then layer on from there. Has that been kind of where you've gravitated to as well?
It's definitely my high up my therapeutic offering window, and it's actually a level 2 recommendation on the TFOS 2 treatment guidelines. I always start with food as medicine and lifestyle, omega fatty acid supplementation. That's where I start. And then that's my foundation. Now I build a house on top of it with these mindfully recommended interventions, and OptiLight is early and often.
So what specifically about OptiLight, which has just been available this year, what makes that different than prior platforms? I've got the M22 Optima IPL from Lumenis. I know there's others out there. I feel like I've had really good success with my patients, but what makes OptiLight different?
Nice, great question. So here's why OptiLight is different. First of all, the algorithms and the platform and the energy delivery is the basis for the FDA approval. FDA approval is a big deal, right? When we're talking about applying OPT-based energy to the skin and to the eyelids. The settings are optimized. You'll see when you do that the user interface is so just simple, easy to flow. There's no chance of confusion. All the safety buttons it's all programmed in there. And the user interface is really, really simple, really straightforward. The other great thing about the OptiLight is the little handpiece. We had a role in developing it and testing it preclinically. And what I absolutely love about this handpiece is it's a small round, and I'm able to get into these incredibly complex contours with elegance and precision. It's much harder to match the contours around the orbit with a flat surface than it is a small round. Ask any carpenter who's trying to wrap wood around a spiral staircase, right? You got to break it up into small chunks to get around those curves. So I love that. Patients love the comfort of the OptiLight pen. They're like, oh, that's nice. and I'm still able to get the results and target treat where the mischief is. I do use corneal shields, metal corneal shields that we sterilize in between patients. And that allows me to treat on top of the lid as well. Don't forget to treat this here, you get a neural stimulation effect by treating in this area here.
And that is much more difficult if you don't have the OptiLight platform, if not impossible in some cases of anatomy. So what I'm hearing is it's going to provide maybe a little bit better patient experience. I think the experience is already pretty good with prior Lumenis offerings, but maybe a more complete treatment because of just that targeted pen and the contours that you're able to treat, and then those vetted algorithms that are now FDA approved for treatment of dry eye. Is that right?
Yes. That you summed it up beautifully.
Yeah,
it's the precision, the comfort, the efficacy that you get with the program system the way it is and the OptiLight pen. That's what I love.
So does the number of treatments for a typical patient, does that change at all? Does the duration between treatments, have you modified that? Is there any change in maybe adding a thermal expression procedure? Has any of that evolved with the addition of OptiLight?
Oh, amazing question. How does it fit into our other things in our toolkit? I have not seen a difference, or I've not had to change my protocol. So typically what we do is 4, typically, unless there's really severe disease, sessions spaced 2 to 4 weeks apart. That sweet spot, we actually analyzed our data and presented at ASCRS in 2019. That sweet spot is right around 2 to 3 weeks interval. If you wait much more than 4, you start to lose that synergistic effect on improvements in MMP9. The MMP9 dropped like a stone with regularly spaced treatments in our data. Lost track of the actual question, but I'm going to kind of keep talking. Oh, yes. And then the expression modalities, I still offer that at the end as the cherry on top. As I'm making this wonderful Sunday dessert, gluten-free and dairy-free and sugar-free, of course, because that's good for the diet of the rosacea patient. And the cherry on top is the thermal expression modalities.
So maybe final question on folks out there that are already doing IPL. I find myself, I'll do the 4 sessions for most patients. I do try to identify people that I think need a little bit more just based on how advanced that disease is. But is there something that you're doing at visit 3 or 4 to maybe intervene and say, boy, I really think we're going to need to do more than what we had originally planned? How does that look in your clinic?
Great question. So we get obviously more advanced patients because we're a dedicated dry eye treatment center. And I've gotten pretty good at predicting at that first visit. I'm like, a lot of people get away with 4, but you're going to need more. Or I could say, I'm not sure if 4 is going to do it for you. Let's do an reevaluation at visit 3 and 4 and see where things are going with the meibomian gland expressibility, with the osmolarity, with the MMP9 load. If that's not adequately controlled, and mind you, this is in addition to my diet recommendations, my hydro eye recommendations, the dietary modifications, and my immunomodulators. It's all working together, right? If I'm not seeing that, then I'm like, you're just going to need more. Or maybe it was a problem with filling one of the prescription medications. The prior authorization hassles are an epic.
That's a challenge. And
oh, my stars. We've got to do something about this. It's not okay.
Well, one way we can help is go after the besto, right?
Yes.
And there's no PAs involved in IPL in the United States, right? I mean, this is a self-pay procedure that you can build a model in your clinic, and I think there's multiple ways to do that. We tend to package this with other technologies if they're appropriate, but we do offer standalone treatment as well. Mm-hmm. We know that these patients are going to need some maintenance therapy, so we do a la carte, a 6 to 12 months treatment. Is that how you do things in your practice?
We do strictly a la carte because of all of those variables we talked about. The comorbidities, do I have control of those fellow contributors to the situation? Flare-up happening? Is there an allergy season over the top of this? So it's I follow the clinical response. It's not cut and dried. I think that's something that we should be talking about as dry eye enthusiasts. is that ocular surface disease is not algorithmizable. You can't, it's not A, B, yes, no, if, then. It just doesn't work like that. It's pools, it's overlaps. It's what I call the Tao to healthy ocular surface disease, the dermatologic, ophthalmologic, and aesthetic overlaps. Derm, aesthetics, ophthalmology, the Tao to healthy, beautiful eyes. And I really do approach it that way.
But that's what makes it so fun, right? If there was just algorithmic, we wouldn't have to use all parts of our brain to try to, develop the appropriate plan and engage our patient to have the best outcome. So I love the fact that it is challenging in that way. I think it would be nice in some cases to have a little bit more A, B, yes, no, but we don't have all of those therapeutics.
We don't have that.
Probably IPL is going to be the closest thing to cover the widest number of elements in that bestow.
True. And I have this chart that I built, and I dove into the literature looking to see where there's peer-reviewed evidence on the different impacts on the bestow. And OPT energy with OptiLight gives you 5 out of the 6 heads. The last one is altered melting temperature. It's not that effective of a meibomian technology, in my humble opinion. That's why we layer on these other temperatures. But the quality of the meibom corrects over time as you address all 6 heads of the bestow. And that's fun to go from non-expressible to toothpaste to turbid to clear. It's like, yay!
That's why I use videography a lot in my practice, and I show patients that, and my technicians are seeing that as well. And it is very rewarding when you get a grade and a half improvement in meibom quality. With IPL, I think it's just tremendous, and I get pretty stoked about it. I think my patients understand it, but when they see that and they say, yeah, this is toothpaste, and now it looks like olive oil, I mean, it's tremendous.
Don't underestimate the power of a gross out, right?
I agree. As we wrap up here, we talked a little bit about existing folks and why they should be maybe thinking about upgrading to the OptiLight, but we have a lot of people here at this Eyes on 2022 that are maybe looking at accelerating their practice by bringing in-office treatment, and I think IPL is a great place to start. What are some of the pearls that you would have for our colleagues, both in optometry and ophthalmology, as they look to 2022 and how they want to manage disease in their own practices?
Right. So I think the mindset is my patients need more. I need to offer more. I want to continue to grow and learn. I want the best thing. And so to me, that represents OptiLight. Now, as far as integrating it into the practice, you already have those patients on your roster, right? That would benefit from the OptiLight approach to their ocular surface disease, meibomian gland dysfunction. And then I would say set up good habits from the get-go. And I'm talking about read up on clean procedure room techniques, read up on sterilization practices, have your procedure room dedicated so that it's easy to jump in, do a treatment, and then jump back into patient flow. Think about it for changing that frustration a lot of our colleagues have around ocular surface disease, and that frustration around the prior authorization process and patient adherence with therapy, cash pay for co-pays, all that nonsense. And think about making a direct contact between what the patient needs and what you're able to offer, and turning dry eye from a prior authorization hoop jumping adventure or fail into a effective treatment in office modality that you can offer in real time. Our patients will even tell us that it decreases the burden of disease. And I think that's something we underestimate when we pile on all these appropriate therapies for our ocular surface disease patients. It's a lot of time. It takes a lot of time, and don't underestimate what they're willing to spend money on for some effective improvements and relief.
Yeah, I think when you can have a great dialogue with your patient and really focus in on what their goals and make sure your goals are aligned with their goals, and you present a plan to be able to get there, they know that it's not going to be in a week or a month. It's going to take a little bit, but you lay that out for the patient as here's where I'm hoping to get to. I do agree that they embrace that. And cost is usually not the biggest concern there. It's really just how can I customize this plan to meet this specific patient's needs. But that's what's the great challenge about it. And then you get the reward as a practitioner on the back end with happy patients that come in just beaming, and it's so much fun.
So much fun. Oh, you're gonna can't wait to hear what you think about it. But yeah, you're gonna love it.
So check out the Lumenis booth, OptiLight. There's a lot of great content from Laura, from Art Epstein. This is something that I think everybody that's interested in being in the dry eye space should look at. Dr. Periman, the dry eye master, great to see you as always. And I look forward to continuing this conversation very soon.
Appreciate you, Damon. Thank you for creating this amazing platform for all of us to just think together and talk about these amazing ideas.
Thanks, Laura.